Interventional radiology will be our next topic, presented by Dr. Afshin Gangi. Dr. Gangi joins us from the University Hospital of Strasbourg. Following his MD at the University Hospital of Reims in France, he performed his residency in the University of Strasbourg in radiology, specializing in interventional radiology. Meanwhile, he obtained his Master of Science in Medical Biology and PhD in laser physics. In addition to being an invited professor in King's College of London, he is Professor of Radiology, Chief of the Department of Interventional Radiology in the University Hospital of Strasbourg, where he also currently serves as Chairman of Radiology and Nuclear Medicine. His many influential publications and lectures, and he has many influential publications and lectures and participates in countless societies, including the European Conference on Interventional Oncology, where he is the Deputy Chairman. Tonight, Dr. Gangi will present on how the Infinix i4D CT is providing solutions in interventional oncology. Dr. Gangi.
Thank you so much. I have 10 minutes to convince you that association of angio and CT in interventional radiology is dynamite. I will try my best. Here we are. As you know, Strasbourg is a quite small city in the east of France, because you should not confund this with Germany. That's on the border with Germany, but in France. It's a quite nice city. The region is about 2 million population maximum, and we have a large university hospital, which two large hospitals, which we are occupying. The hospital has about 12,000 employees, 2,000 beds, and we are seeing every year 23,000 patients just in IR as a consultation and seeing patient, and we are treating 13,800 patients a year in 5 different operating rooms. This is our activity. We have access to CT scan, to CT angio, you have seen, the MR, ultrasound, sure, and even twice a month to PET CT for our intervention and a dedicated MR scan, all completely. I'm very lucky to work with a full team of nurses, secretaries, assistant, radiologists, interventional radiologists, and specialized technicians who are just doing interventional radiology and nothing else than this the whole full time. We are lucky to have our first Infinix CT suite about 1 year ago, which is equipped with an ultrasound and Angio-CT, as you can see here. We are working with the system since this year, and we are very happy to have this combination of both machines. As I'm telling always, when you have a room like this, you are able to push the boundaries of indications and push forward for the patient, for the interest of the patient, procedure which is becoming more and more challenging because you have this double parachute. Anytime you're in trouble, you know you have a background, something else coming to help you, and you have both together. Having both together means you are using your majority of your procedure sometime on CT scan. We are going in this room with having angio and CT in the same time. Usually we know that we will use the CT scan a lot. The angio part will be used too. But anyway, if you are doing more than 6 scanning, CT scan in the room, you need to be in such a room like this, because with the cone beam, you will need a lot of radiation and a lot of time to do it. Look at the procedure like this, which is just a liver ablation with a very infiltrative tumor. In such a case, when you have such an aggressive tumor with such a hazy borders, you know the ablation should be large if you don't want the recurrences. The problem is you have seen the heart is directly on your way, means if you are doing a blind ablation, you will make a nice hole in the heart. The patient will die during the next 6 weeks by perforation. You don't want that. Means for such a procedure, you need a lot of scans. Low dose scans, which is done in 0.3 seconds, you obtain a volume of 4 centimeters very quickly, and you can see exactly your instrument. And if your dissection is really protecting the heart, in those cases, then you can go in, put your probes in, and do a large ablation in full confidence of not damaging the patient. That's essential to do this. Another example, quite similar. Again, you see in such cases, we have the tumor very near the heart, we are near the stomach, and again, in this case, the dissection should be perfectly done. And the problem is, we have a problem at the end. We were not seeing any dissection between stomach and the liver tumor, which means with the microwave, we will be sure we will ablate the stomach. And this is, again, something you don't want to have. And having the 4D CT means, in the real time, we have seen that when we are doing our dissections, in real time, we are having a nice dissection between the liver and the stomach with continuous injection. This was not visible with conventional CT scan, where we're doing the scan, no fluid. But continuous acquisition was showing us the dissection is there, safe, we need to inject continuously, the fluid is done. Another case of the liver, as you can in this case, again, I'm showing you the worst cases. We have inflated the stomach to push the pancreas far away from the tumor. And again, as you can see, we tried to dissect the stomach. The problem was it was not happening. The fluid was not standing. In this case, because we have 2 dissection needles, we can use the needles to do a leverage and push just the stomach away from our way and have an space. Means you are doing a leverage system to remove the liver as a mechanical system to push it away. So you have, again, a space of security. All these are happening because you have those instruments which are giving you the best imaging, real-time imaging, and you can rely on them. You can have a volume of up to 16 centimeters if you need to see well the whole region in a few seconds. That's important to know that you have those parachutes to do it safely. Another thing you're using more and more, especially for the lung ablation sometime, you are having a lesion like this one, you are doing an ablation, you can use the perfusion imaging, means to see if you have done real ablation and devascularization of the tumor. In our experience, we have seen when we control the patient on PET-CT, the devascularization zone obtained with perfusion is quite similar to what we have done in reality. Another great indications of having both systems in the same room for central tumor of the kidney, like this one. Those are the problem. The vessels are around. Having a large ablation is difficult. That's a single kidney. Surgeons are telling me risk of nephrectomy is high, do something. In those cases, we learn if we are not closing the vessels, we cannot obtain a large ablation. But because it's a single kidney, I don't want to go and do a large ablation. In those cases, what we do, we program our ablation, we put our cryoprobes in under CT scan, we do our dissection, we push the ureter away, everything is safe. At this moment, we come in the room with the ultrasound, we puncture the radial artery, we get in the kidney, and just during the ablation time, the 10 minutes, we inflate the balloon, we make an occlusion of the balloon, means we stopped the blood perfusion of the kidney for 10 minutes, so we have a large ablation, we don't have any loss of energy deposited in the kidney, and you have large ablation without damaging the kidney because just 10 minutes occlusion and cold occlusion. And as you can see, very nice ablation obtained. Without this, it was impossible, believe me. How long it is to push from one to the other? Because this modality needs to move. Now with the automatization of the system, in less than 30 seconds, the patient come automatically out, come in the fluoroscopy mode. Means you don't need to push it manually. Everything is done automatically, and the machine has in his memory the position you need to do. Pushing forward again. This is a case, a poor patient, having a metastasis of C2, fastly progressing. Radiotherapy is done. The patient has a fracture, unfortunately. He fractured the odontoid bone. Surgeon told me, or orthopedic surgeon, which we work very closely with, said, this patient will not live more than 3 months. I will put him in a cast, and that's it. I cannot do anything else. Then we have studied how can we do it, because cement alone, as you know, is good for compression, but not for torsion. Means this bone cannot be consolidated by cement. It will break. And any motion of the neck can break, and you know what it means in situ. Is the hangman fractures, they will die. Means this is a sudden death in this case. What we have tried to do in this case, as you can see, we began to dissect the lateral space, carotid space, pushed away the whole oropharynx. When it was done, at once we put the trocar up through the dissection space, through the odontoid space with the trocar. We get inside the fracture zone, and once we are in, we can dilate it. Dilatation was done, and then over this, under fluoroscopy, we dilate the space, we put a screw, like the surgery, to consolidate the whole bone and odontoid system, and the basis of the screw was injected with cement, so you have a nice consolidation, which is dynamic for this patient. This changed the life of this patient. The 3 last months, he don't need to have this cast. He has the best quality of life. This is possible with some two suture, not open surgery, and excellent quality of life. We are pushing forward even with our surgeon. Our room, the 4D CT room, is a 5-star, all-inclusive hotel. Means when the surgeon needs to do something special, they are really welcome to our room. They have us, technicians, nurses, and themselves to do stuff. That's what we do with Hervé Lang. Here you can see one of my best friends. When they want to do a very complicated ablation, resection of partial nephrectomy, patient is quite large. You know what they do first? They need to go to the vessels, find the vessels first, put clamps on them, and then they go to find the tumor. They find the tumor. The moment they're on the tumor, they clamp the vessels and they operate. We tell them, you don't need to do this. We go taking care of the vessels, as you have seen with the balloon. We find exactly where are the vessels. At the moment they find their tumor, even the trocar position on their CT scan, directly on the tumor. So at this moment, they go in there, they tell me, I find the tumor, and even sometimes they ask us to inject some blue, so the tumor become blue. Say, okay, I have it. Close the vessels, we close the vessels, and they can resect nicely the whole tumor in our room, as you can see, without any blood loss. All these are the projection of this. You will tell me, should we have those rooms? We have cone-beam CT, you remember? You remember every cone-beam CT you do, you have some radiation. You cannot be centered. The field of view is limited. For large patients, the whole liver cannot be seen. It's perfect. I'm using cone-beam CT every day. But however, for difficult procedure, when you need more than 6 CT scans, you need to have such a room. And as I said, look at this radiologist, interventional radiologist. He has to do this ablation. You put him in a cone-beam room, and you say, do it. Which one have been in the cone-beam room in your point of view? Here we are. That's very easy to know. First of all, he was in because he stressed a lot. I can tell you, when the procedure is difficult, you are sweating in the room. I swear to God, it's stressful. If it's difficult. Second, he was really tired watching the screen to see exactly what he wants to obtain, doing cone-beam again and again. And third one, you should know, those procedures are quite time-consuming. He has a grown of his hair during the procedure. Means there are times you want to have something good and to look cool. Sure, I can understand with many of my colleagues, what you don't have, you don't know. Means you say, I don't need it, but the day you have it, you cannot come back. The comfort of such procedure are unbelievable. To tell you something, that since we have the machine, our hospital, our surgeon have asked for a second 4D ECT, and we are being lucky to have soon a second system, and our Infinix will move to the new hospital, and our new room will be equipped with Alphenix, means the new machine, which has his smaller, faster, and even better imaging. You can see if Strasbourg, a city which is just the 4th or 5th university in France, is getting me a second machine, is not because I'm looking good, or I'm talking, or I'm joking. It's just because surgeons have asked, we want to have the same room in the hospital, in both hospitals. Thank you very much.